better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hi, everyone. Welcome to this episode of No One Told Me, the Airway Health Connection. I'm Dr. Liz Turner, and today we're going to be walking through something you may or may not have heard of, primitive reflexes. Primitive reflexes serve a big purpose for growth and development and breathing. And so today we're going to dive into what they are, how they can affect us, and also how many of the symptoms overlap with oral restrictions in airway health. So what are primitive reflexes? They ultimately are the foundation of the brain. Think about it like learning to read. You can read words on a page, but once they were just squiggles on a page, then they became letters, and then they became words, sentences, and eventually a story. The squiggles, the lines on the page, those are the primitive reflexes. It's only with practice and repetition that they can become more organized and purposeful. Our body cannot function without brain power. But when we're born, we function based on reflexes that are designed for our survival. These are temporary, automatic movements that should be inhibited or replaced by voluntary, purposeful movement patterns as the cortex and cerebellum mature. When this doesn't happen, we say a reflex is retained. From a developmental perspective, primitive reflexes serve as the developmental building blocks of all brain development. If they don't mature properly, the rest of the brain cannot develop efficiently either. Most of these primitive reflexes integrate before the first year of life, but in so many of our children and adult patients, if they're not integrated, this pyramid is not as stable as it should be. When we look at the brain from infancy, we can begin to see that the building blocks just don't fall where they need to if a misstep is experienced. If these primitive reflexes are still running the show of the brain, they can create friction in the system. A retained reflex is like having an automatic reaction constantly overriding what we want to do, our conscious control. For dentists that are listening to this, I'm sure there are many of you listening that haven't heard of reflexes beyond the moral of the suck. And same thing for parents. If you haven't heard of these reflexes, your providers need to be asking better questions and thinking about how they can impact. But for a lot of the therapists and lactation consultants that are listening right now, you're all nodding your head saying this is what we're missing. Building a team that understands these concepts is essential. In lactation, occupational therapy, physical therapy, chiropractic care, we look for these things. But have you ever really heard of a pediatrician or a dentist that routinely addresses them? Because if these reflexes are still taking over and retained, not only can the body movement patterns be compromised, but the brain's ability to process and react to stimuli can be as well. These symptoms can reach from infancy through adulthood. These early signs are often brushed off, but they're frequently a call to investigate deeper as we have to get to the root cause. Some early signs that something could be off are difficulty latching or feeding, asymmetrical movement patterns, poor sleep, chronic mouth breathing, startle responses, hyperactivity, delays in crawling, walking, or speech, and nocturnal enuresis. But wait. Isn't this a symptom list of oral ties and airway issues too? Absolutely. This overlap can make it hard to differentiate between the two as separate issues, in part because there is an overlap between the two. So what came first, the chicken or the egg? The age-old question. Does it really matter? Because they go hand in hand. We just need to be open to awareness beyond the treatments that we're rendering. As we dive into the brain-body connection, the body must be free to move in dynamic reciprocal patterns. Fascia, tone, and oral restrictions impact this movement quality. Reflexes are motor patterns. They require mobility to integrate. And here's your neuroanatomy lesson. Let's start with the brainstem. The brainstem is the most primitive part of the nervous system, and its job is survival. This is where breathing, heart rate, feeding, posture, and primitive reflexes all live. In infancy, the brainstem is meant to be the dominant aspect of the brain, reflexive, automatic, and protective of the system. The cerebellum, it's the regulator. It's behind the brainstem. It integrates sensory input, vestibular, proprioceptive, and tactile. It coordinates smooth, efficient movement. Most importantly, this is where the primitive reflexes become inhibited and integrated. The amygdala is the brain's threat detector. It receives input in part through the vagal pathways. Think about fight or flight response. Its job is to keep us safe, not necessarily to help us integrate or learn. When the nervous system perceives danger, whether from pain, poor breathing, inflammation, trauma, the amygdala takes over. And when this happens, the cerebellar regulation drops and the reflexive protective patterns reemerge. This is why we often see retained reflexes alongside anxiety, emotional reactivity, and sensory overwhelm. When we think about how these reflexes integrate, it's from repetition and movement along with a calm nervous system. They go from the brainstem to the cerebellum and eventually to the higher order cortex. Integration is developmental, it's not behavioral. And movement of the body drives the maturation of the brain. Inflammation and lack of movement can cause the amygdala to be in overdrive. The problem is that anything that keeps the nervous system in survival mode can interfere with this integration process. So chronic inflammation, poor sleep or breathing, nutritional deficiencies, gut imbalance, sensory overload, structural asymmetry, trauma, they all signal threat to the brainstem. And when the system is inflamed, under-resourced, or asymmetrical, the cerebellar regulation drops. So that's why it's extremely important for us to factor in things like food irritations or inflammation associated with exposure to environmental pathogens such as mold or other viruses. It's really important that we look at the whole system, not just the oral structures we're treating. And how does the midline relate? The brain organizes movement, posture, and coordination around the midline of the body. When there are midline restrictions, such as tongue ties, torticollis, cranial strain, or pelvic asymmetry, the brain will receive uneven sensory input. The body wants symmetry. The brain wants symmetry. Asymmetry reinforces this asymmetrical reflex firing, especially of the head and neck driven reflexes. Until the midline is free and balanced, the nervous system will struggle to fully integrate these reflexive patterns. And I would be ignorant to not recognize that many of you listening to this podcast today are extremely familiar with oral restrictions. Maybe you're a parent and you've been through this with your own children, you're diving deeper. Maybe you're a provider and you're looking to learn more. So I'm aware that many listening understand the tongue tie. And you're looking for the functional improvements that can come with a properly prepared for and timed release. But unfortunately, for many in the medical community, it's just not that in depth. It's black or white. There's either a tie or there's not. For today's purposes, we are discussing primarily ankyloglossia, tongue restrictions, but of course, labial and buccal restrictions can limit movement patterns and muscular compensations as well. Function depends on the tongue's ability to move freely, extending, elevating, and creating peristaltic motion. Beyond feeding, tongue ties often show up as tension patterns throughout the body, so they can impact movement. When commonly we'll see torticollis, difficulty with tummy time and extension, limited neck flexion and extension. When movement feels hard or uncomfortable, babies naturally will move less. And then if we add in prolonged time in containers, swaddles, rhythmic rockers, these opportunities for integration decrease even further. Without free, repetitive movement, the brain cannot build efficiently from the bottom up, and the primitive reflexes struggle to integrate. If the body is tense, the reflexes can be impacted. If the brain is in fight or flight, possibly from feeding, oral ties, discomfort in a child's body, reflexes will be impacted. Remind yourself that as we are treating the structures and the function of the oral cavity, we are addressing body tension as well. We also need to recognize that the brain may need additional support too. Many providers screen for and make recommendations for this, but many do not. As providers, we need to be on the lookout for when things aren't getting better in our patients. Let's walk through individual reflexes. As we walk through some of these most basic and common ones, I want you to think about your patients, your family, even yourself. Can you think of a case where the reflexes could have been or are part of the problem? Let's start with the Moro reflex. The Moro reflex is a primitive startle reflex designed for survival. It begins in utero and it helps the infant respond to sudden changes in position or sensory input. This reflex typically integrates between 4 and 6 months of age as the nervous system matures. Retention of the Moro reflex, it often presents as heightened startle responses, sensory sensitivity, difficulty with emotional regulation, sleep challenges, and increased anxiety or reactivity. These are the kids that can't stand an automatic toilet, the high-speed suction terrifies them, and overstimulation can send them into a tailspin. Imagine a child at recess. I describe my son as kind of a playground vigilante, and he's got a pretty strong retained Moro. A ball suddenly flies past a child. Another kid bumps into him, the whistle blows. Most kids can startle and recover. But for children with a retained Moro, they stay stuck in the startle. They overreact, they freeze, they melt down, or they bolt away. It's not their behavior. It's just that their nervous system is interpreting these normal play as a threat. They can't respond to the stimuli rationally. In a normally integrated Moro reflex, the startle response fades and the body remains calm. With retention, the nervous system overreacts to sound, touch, or movement. Oral restrictions can contribute to chronic tension and poor vagal regulation, which can amplify the startle response and sympathetic dominance. So when testing for the Moro, it often involves being in a standing position, and a provider will gently but also surprisingly tip the child back. If the arms fly up instead of staying low, what we suspect is that the Moro reflex is retained. They should be able to be putting their hands back to brace for the fall, not startling and reacting against it and raising up their arms. Moving on to the rooting and sucking reflexes. These are separate reflexes, but they function as paired oral reflexes that support early feeding and sensory organization. They also support midline coordination. For teaching and for clinical clarity, it's best that we talk about these together. Retention can show up as difficulty latching, head turning with touch, feeding inefficiencies, oral defensiveness as well. When retained, the oral system, it'll stay immature, and that can lead to messy eating, speech issues, and oftentimes oral fixation. So how many of our kiddos are fidgeting with their clothes, putting their lovey in their mouth, biting their nails? That's a retained rooting reflex. Restricted tongue and floor of mouth mobility can limit the extension and peristaltic motion of the tongue, which can alter the oral sensory motor patterns and reduce the opportunity for reflex integration from a young age. The palmar and plantar reflexes help build early grasp and grounding. So this is when you put your finger into the child's hand and they immediately grasp, or you stroke the baby's toes and they curl their toes. So the palmar and plantar reflexes, they're primitive grasp reflexes of the hands and the feet. They're present at birth and they help the infants connect to touch and movement, grasping with the hands, grounding through the feet. These reflexes lay the foundation for later voluntary skills like reaching, releasing, standing, and eventually walking. When these reflexes remain active, we can see different signs depending on age. In infants, this can look like prolonged grasping, difficulty releasing, or sensitivity when the feet contact surfaces. Think about a kid who you're putting them down on the sand and they immediately react. I think about that a lot whenever we're at the beach. I'm from Maine, and that's kind of our sand. It is cold and wet, but at the same time, whenever I see kids doing that, I now think about the plantar. In older children, the retention can show up as fine motor fatigue, poor handwriting, awkward pencil grip, toe gripping, difficulty with balance. I personally hold my hand in a palmar grasp. I do my dentistry with a normal pincher grasp, so I have fine motor control, but my default is to go back to that palmar grasp. These patterns, they're not strength problems. They're really nervous system that's still relying on this reflexive control. So when these reflexes are integrated, the hands and the feet can relax at rest and activate only when needed. The grasp and release is smooth, it's purposeful, and the feet can ground the body efficiently. With retention, we're going to see constant tension. Hands that are gripping too hard, feet that are struggling to stabilize, maybe we're back and forth on one foot. This persistent tension increases effort and fatigue and can affect everything from writing to walking. We spend a lot of time in my house telling my son to hold his pen right, and I realize so frequently that I'm telling him to do something his brain isn't controlling well because we haven't worked on integrating this reflex as well. The spinal galant, let's move on to one of my favorites. The spinal galant is the coolest reflex, I think. It's the reflex that helps the baby wiggle through the birth canal. It supports early trunk movement. With contact, it stimulates the hip movement and the coordination between the upper and the lower body, so it creates a wiggle. When it's retained, it can show up as fidgeting and sensitivity to touch. It can often be mistaken for ADHD or attention issues. Because think about a kid in class whose waistband is rubbing lightly against their skin or the back of their chair is contacting their lower back. For most kids, they can filter out that sensation. But for children with a retained spinal galant, that light touch is going to be really triggering, and it's going to trigger an automatic trunk hip response. They're going to wiggle, they're going to shift, they can't stay seated, and it's not because they're distracted, but because their body is reacting reflexively. This same reflex pathway is closely linked to pelvic and bladder control. When the spinal galant is active, nighttime bladder signaling can be disrupted, contributing to bedwetting in some children. So a lot of our kiddos that come in, they're still wearing a pull-up. I'm like, that's a really triggering sensation on your back. And so if you have a kid who's not sleeping well, and they also have a retained spinal galant, could it be airway? Could it be reflexes? Or could it likely be both? As an airway dentist, when I have a child with nocturnal enuresis, I immediately am thinking airway structures because breathing poorly at night is also linked to nocturnal enuresis. But what if we treat the structures and the nocturnal enuresis isn't getting better? Your treatment didn't fail. It's just that you may need to look for the next layer of the onion. In integrated spinal galant, if you have a child on all fours, it's going to show that there's no trunk response to touch. So you can take your fingertips or a paintbrush or like a feather, whatever, have them on all fours and you can run this down their back. If they're responding by going away from it, that retention is producing a hip or trunk movement with that stimulation. If they're just staying stable and they're staying on all fours and the back isn't moving, they don't necessarily have a retained reflex. This midline tension pattern, including fascial connections from oral restrictions, it can contribute to the trunk instability and some of the sensory reactivity. So that's where we'll see an overlap between oral ties and the spinal galant along with airway. Moving on to the ATNR, the asymmetric tonic neck reflex. This is going to support early hand-eye coordination. It typically integrates by 6 months of age, and this is your classic fencer pose. So think a head turn, the arm straightens and opens, the opposite arm bends in and pulls inward. So think about that baby, they turn their head, their arm extends, their leg extends, the opposite side bends and folds inward. The body is organizing around the head position. It's not an intentional movement. This is the reflex that helps the baby begin left-right coordination, so the asymmetric each side, crucial for rolling, reaching, and tracking. Retention can include difficulty in crossing the midline, one-sided posture, handwriting challenges because there's often an ocular and vision tracking issue as well, and torticollis patterns. So the problem is this fencer pose can often be perceived as clumsy as a child ages. Think of it like this. If it's not integrated and you've got a kid running at recess, she turns her head to the right. The right side comes out. The left side comes up and in. The balance is off and she's perceived as clumsy. This isn't a coordination problem. It's a brain reaction problem. When it's integrated, the head can turn independently without arms bending, When retained, limb extension is going to occur with head rotation. Cervical tension and midline restrictions, including tongue ties, can reinforce these head turn preferences and asymmetrical movement patterns. So we have a child on all fours. We have them turn their neck, turn their head to one side. If the arm bends of the opposite side, the reflex is retained. If the arm stays straight, it's suspected the reflex is integrated. Moving on to the symmetric tonic neck reflex. So we just did asymmetric. This is symmetric, STNR. It supports the transition to crawling. It does show up a little later than birth. It shows up about 6 months, and it integrates between 9 and 11 months of age. This is the reflex that bridges the upper and the lower body. It helps the baby move from belly to crawl to stand. It is a huge deal that crawling is no longer recognized as a milestone, because many of these kiddos that are missing crawling as a milestone have a retained STNR. Retention can show up as poor sitting posture, W sitting, difficulty with desks, and coordination challenges. An integrated STNR allows independent head and limb movement. Retention links the upper and lower body movement to the head position. Oral and cervical restrictions, just as with the other reflexes, can interfere with this head-neck dissociation, and it can impact postural control and transitional movement. So you'll still have the child on all fours. They're going to be bending their head down. If the arm's bent, then the reflex is suspected to be retained. If the arm stays straight, the reflex is suspected to be integrated. And I'm not checking these reflexes on all kids. I'll get to kind of the point of all this in a few moments, but it is important to recognize that when you have a kid sitting in your chair and they're fidgeting all over the place, or you actually see them toe walking, you see them W sitting on the floor playing with your toys, you see that they have to lean up against everything. You can even, just ask the parents if they're overly stimulated to certain noises. Like, how do they do in a public bathroom where the automatic toilet goes off? How are they on the playground? How is their relationship with peers? So moving on, this is the last one I'm going to cover. It's called the TLR, the tonic labyrinthine reflex. There are two parts of it: flexion, which typically integrates around 4 months, and extension, which begins to integrate around 6 months, but it can take longer. The TLR helps babies orient themselves in space. It's key for posture, balance, and movement. Flexion, or bringing the body inward. Extension, helping the head control as the body learns to Superman and extend. Its role is to support head control and postural development. It typically integrates by 6 months, but again, the extension aspect of it can take up to about 3 years. If it's still active, kids can look slouched, uncoordinated, dizzy. They never appear really grounded. Retention can include poor balance. It can include toe walking, altered muscle tone, and difficulty working against gravity. So really, their just perception of where they are in space is just off. Global tension patterns and restricted midline mobility can alter this flexion extension balance and the postural control against gravity. So it's important to recognize the TLR is kind of one that kind of brings everything together. It's the spatial awareness aspect, and the trickle down of it is so many of the other overlapping symptoms between the other retained reflexes. So you may be thinking, I just still don't understand why this matters to me. Like, I treat oral restrictions. I'm a dentist. I help the train get down the track. But what more should I be worried about? Well, it matters because of the symptom overlap on the airway side. When we don't breathe well, there's inflammation in the system and we have too much tension. The chance that multiple reflexes are retained is high. And this is foundational for coordinated movement and posture. Active primitive reflexes, they interfere with balance, midline control, and efficient motor patterns. We can see asymmetry, poor posture, lower high tone, difficulty with coordination. Once these reflexes integrate, the movement becomes smoother, more intentional, less effortful. Think about kids struggling in sports. I think about my son on the soccer field who just wants to play goalie. And part of it is he can't turn his head to track where the ball is without his whole body being completely out of balance. We've gotten him into CrossFit and jiu-jitsu, and his ability to cross and manage the midline is so much better. I just think of the years that we missed in terms of being like, why doesn't he seem more coordinated? Why doesn't he do this? Why doesn't he do that? When we really could have been looking at the basics of the brain the whole time. When we think about sensory processing issues, primitive reflexes shape how the brain receives and organizes sensory input. We want sensory information to be processed smoothly and efficiently. When reflexes are retained, the nervous system will stay reactive. Sounds can feel louder, touch can feel overwhelming, movement can feel disorienting. It can also be the opposite. This is why retained reflexes are so often associated with sensory defensiveness or sensory seeking. Integration allows the brain to interpret this sensation rather than just reacting to it. So the higher order thinking can take over versus just reactivity. And finally, emotional and cognitive impacts. When kids are struggling with impulse control, emotional outbursts, anxiety, we often in the medical community are just jumping to behavioral labels. What could we label this child with? What could we medicate them with? But what if it's neurological? What if it's brain foundation? These kids are not bad kids. There is nothing wrong with them. Nothing. Their brainstem is overriding the ability to self-regulate. And it just breaks my heart to think about how many kids are suffering because of something that could be so easily assessed for and worked on. Not to say it doesn't take time, energy, but at the same time, we should be doing better for kids. Retained reflexes, they keep the nervous system closer to survival mode, and it makes emotional regulation and attention more difficult. Children can appear anxious, impulsive, easily overwhelmed, fatigued by learning. Like that kid that comes home from school and they're just a disaster because they've had to put on this face all day and try to manage and regulate something that's having a hard time regulating because the higher order thinking isn't taking over. When these reflexes integrate, the brain will shift from protection to higher level thinking. This regulation, it creates the foundation for focus, learning, emotional resilience. Retained primitive reflexes, they keep the nervous system in survival mode. But here's the thing I want to highlight. This is not just our kids. This is adults. Adults with retained reflexes are often living with chronic tension, poor posture, movement inefficiencies. What looks like clenching, slouching, poor coordination, it's often the nervous system running on outdated wiring from early development. In adults, retained reflexes, they don't disappear. They show up as compensations. Chronic tension, postural fatigue, dizziness, motion sensitivity, clumsiness, they often reflect a nervous system that's still organizing movement reflexively. These patterns can influence how we sit, we drive, we write, even how our muscles hold tension throughout the day. Over time, the body adapts, but that adaptation, it continues to come at a cost. What looks like normal wear and tear, it can actually be the nervous system working harder than it needs to. And when we think about the emotional side, emotionally retained reflexes, they're keeping that brain in survival mode. Anxiety, reactivity, sensory sensitivities, difficulty focusing, they're often signs the nervous system never fully matured, not personality flaws of a human. In adults, these can really affect regulation. When that nervous system is in survival mode, we're going to see heightened stress responses, anxiety, irritability, difficulty focusing, emotional fatigue. When the reflex patterns persist, the brain is spending more energy on protection and less on efficiency. Supporting this integration can really help shift the system from constant alertness to stability and resilience. So now are you starting to see it? We treat the tongue tie, we treat the space, we treat the airway through dentistry that we do. But by adulthood, these reflex patterns, they don't just disappear, they become adaptive. So we've let this go on. Like watchful waiting doesn't aid us in a lot. The body is finding ways to compensate through tension, posture, breathing, movement. Oral restrictions matter because the tongue sits at the center of this midline, and it plays a huge role in breathing, head and neck posture, and nervous system regulation. When the tongue mobility is limited, these compensations can persist and reinforce the reflexive patterns instead of allowing efficient integration. This is why addressing oral structures in adults isn't about feeding. We know that. It's about function, regulation, and resilience for that body. So how do we help our kids and ourselves? What can we do? Well, we can just keep assessing structure, function, and habits. We need to do that. We're treating the cause, not just the symptoms. We need to keep building interdisciplinary care teams that are unique to each person we work on. We need to manage every case with this functionally minded, collaborative approach. We can guide growth naturally where possible through baby-led weaning, breastfeeding, oral posture, play, movement. Then we can intervene where growth and function have gone awry. Maybe we need to do tongue tie releases. Maybe we need expansion. We need myofunctional therapy. We're intervening to help the growth go on a better trajectory. But my call to action is this. When we are seeing persistent or evolving airway symptoms, they require ongoing evaluation. They require clinical curiosity, and they require timely interdisciplinary referrals with direction. So I challenge you to make better referrals. Like, we should be doing this in dentistry. We shouldn't just say evaluate for ortho. We should say evaluate for arch length discrepancy, more space indicated, discuss adult expansion options versus orthognathic surgery, risks, benefits, reviewed with patient, please confirm, CBCT taken. Like, use better verbiage than just refer to ortho. Let's think about how we can make better referrals in other spaces. So continue to hold our place in this medical system by doing so, by communicating better. For example, I'm referring Paxton for occupational therapy for suspected retained ATNR, STNR, and Moro reflexes. We've optimized the oral structures, we've addressed oral restrictions and function, and we are seeing symptoms persist. Let's do better with our verbiage so that we can help guide treatment when things aren't getting better. Because we could just say, we did our job, we expanded. We did our job, we released the tongue. But did we really do our job if we didn't help go past those boundaries for full symptom relief? So resources are available, and that's the hard thing, is finding people who work with pediatric populations, with adults. There's a lot of different modalities that can be done. And I would really like to highlight my colleague, Dr. Nichelle Groulet. She is at Live Loud Chiropractic, and she's launching an app called Rewired Kids. So for parents listening, this is a great way to get your children started on functional brain movement patterns that really can make a difference. You can also reach out to all different occupational therapists, chiropractors. Functional neurology is a great place to look, though there are different schools of thought and how those cases are managed. So if you're looking to work with children, it's important to make sure that they see a pediatric population. There are a ton of resources available when it comes to the literature, but really more is needed. I can't think of a single paper that I've been able to find or book that I've been able to find that's directly discussed children with oral ties and then tested those reflexes a few years later. Maybe this is something that I could do one day, but we need better literature that really supports and offers a therapeutic treatment strategy. Again, I think the best thing we can do is early recognizing what's presenting in front of us, and then making good referrals to improve on the function of that body, whether it be through oral health and expansion and myofunctional and tongue releases, whether it be through body movement and posture, because that's really how we optimize these systems into adulthood and prevent some of the bigger stuff. When we recognize that primitive reflexes are impacted by tension and trauma in the body, we can respect that the two go hand in hand. We can begin to look not just with tunnel vision within our professions, we can expand to interdisciplinary care. Because through collaboration and assessing, when treating both the structure and the function, we are in a unique position to help children thrive as they progress through life. I'm so excited that you have the opportunity to help watch your patients, watch your kids thrive. We are so lucky to be in this space and asking these bigger questions. I am so happy that you were able to join me on this episode of No One Told Me, the Airway Health Connection. I'm Dr. Liz Turner, and I am pumped that you're here on this journey with us.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
Want to learn more about Airway Health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye!